from or what domains we'll be dipping into. And the Institute of Ethics is a very broad tent. We are developing expertise in 6 general domains. 5 of those are in ethics. So those would be clinical ethics, professional ethics, organizational ethics, research ethics, public health ethics. And then the 6th domain is humanities. And there is a tradition in medicine and nursing that draws on insights from the humanities to help us to be better clinicians. But there's also a newer reverse trend where humanities, people who are working in the humanities are drawing on our practices in medicine and nursing to learn more about humanities. So the 6th domain that we will present topics from will be the humanities. So we'll have a very mixed bag, and I hope the talks will be of interest to everyone. As an example of organizational ethics, I'm very glad and very pleased that Dr. Paul Roth is going to give the next talk next month, and his talk will be on what he's learned as a leader of our institution for so many years, and that will correspond to issues that emerge from organizational ethics. So for now, the series is going to be monthly. It's going to be by Zoom, and the schedule will be up on the website. I'll put the last slide of today's presentation. We'll have a list of the upcoming talks, and you can get a sense of the range that we will be presenting on. So I'd like to switch now and present a talk about miracles. And I'm not going to examine miracles as a concept or trace its metaphysical commitments that an ethicist, like a philosopher might, or a meta-ethicist might, and nor am I going to examine the beliefs that people actually hold about miracles as, say, an empirical ethicist might or a social scientist might. But instead, I'm going to approach the topic as a normative ethicist. And what that means is that we're going to ask, what should physicians do when their patient or a representative of the patient makes a decision about treatment or makes a claim on them as providers that rests in part in a belief in miracles. So I'd like to present a case that involved an appeal to miracles. And it's actually my first case as a clinical ethics consultant. I later discovered that it's actually not an uncommon reason for an ethics consultation, but it was really fascinating to me, and I've thought about it a lot since. So as clinical ethicists, we tend not to discuss issues of miracles as an abstract philosophical problem. We encounter miracle talk in really complicated social and clinical situations. We don't study them in isolation. This is the swamp or the thicket that practical ethicists must make their way through. And this case is no exception. The case isn't as thick or as swampy as it could be, but it's plenty complicated. So let me describe the facts of the case. The case is both tragic and ordinary. It's not a headline ethics case. It might not be an ideal case for an ethics case study, but it is a real case, and it's useful both in its ordinariness and its limitations. We see these cases all the time. It is only one kind of miracle case. It's not the only kind, and it's probably not the hardest kind, but it's a good way to start off, I think. So the patient, Mr. B, was an 86-year-old man who had moved with his wife, his second wife, from California to New Mexico about a year before his illness. They didn't have any local friends or family. And about 5 months before we were consulted, he suffered a left cerebellar hemorrhagic stroke that caused an intracranial mass effect that resulted in profound motor and cognitive deficits. Amongst the other interventions were a tracheostomy and a PEG tube. And eventually, he was discharged from the hospital to a local skilled nursing facility, or a SNF. However, while he was at the SNF, he removed his PEG tube 3 times, and at least once this resulted in acute respiratory failure and hypoxemia. And as a result, he was rehospitalized after a number of months, and he had stayed in the hospital since then. Psychiatric consultation resulted in a judgment that he was unable to make his own decisions about his medical care. And there was no known advance directive to go by. So his wife assumed decision-making responsibilities as his surrogate. So eventually the medical team sought an ethics consultation, and as every consultant knows, the first question for a consultant was, it was actually famously stated by a sociologist, Irving Goffman, and the question is, what's going on here? And it soon became clear that the situation that we had been invited into wasn't one of moral uncertainty. It wasn't one where one or more parties weren't really sure about what the right thing to do was. It was actually a situation of moral conflict where the parties disagreed with what the right thing to do is. So our first job was to discover the arguments that were being made by each side. And as is usual in most clinical cases, it's probably arguments more generally, is that arguments are not always made forthrightly and clearly. The consultant really has to take time to draw them out, see which arguments are laid on the table first, see which arguments are held back until later. And then often we have to sort of clean them up a bit so that they can be coherent. So what were the arguments that that each side was making? So the treatment team's arguments, the treatment team believed that Mr. B is never going to regain sufficient cognitive or motor functioning to allow him to live independently, and he's going to require ongoing care. And at this point in his illness, the acute hospital is no longer the appropriate place for him. And they recommended that he be discharged to a long-term care facility that would also provide rehabilitative services. Another issue that was brought up in a sort of roundabout way, or in a sort of sotto voce way, was that, well, he's actually not paying for his hospital stay. The insurance company, up to that point anyway, had not paid the hospital bills. I don't know the details, but it did cause some members of the team to make a justice-based argument that he should be discharged because, one, he wasn't paying for the bed, and other people could be occupying the bed, and the hospital could be getting revenue. However, these arguments didn't come to anything. The attempts that they made to transfer the patient to local facilities weren't successful. The VA said they would accept him, but only as a hospice patient, and they wouldn't provide supportive care. Other facilities required that he be on a lower rate of oxygen, or that they wouldn't allow him to use mittens or soft restraints to prevent him from extubating himself again. Out-of-state rehabilitative centers were also a possibility. However, The wife refused to consider a facility in Arizona because of the distance. Another facility in Texas considered the case, but the patient's insurance carrier refused to reimburse for these services. The team learned through back channels that some facilities that might have otherwise considered him had refused because they thought that the wife's demands were unreasonable. And the team ultimately or eventually actually began to suspect that she was intentionally thwarting their discharge plans. So what were the wife's arguments? Over time, the wife made different arguments about why her husband shouldn't be discharged. She said that she believed that he will regain full functioning, or at least enough functioning to be able to live independently. And for this reason, she refused hospice treatment, hospice placement at the VA. She also argued that the hospital should provide long-term care and rehabilitation services. She believed that the team had given up on him and that it was now up to her to press for his needs. She was reluctant to consider him going to an institution in the community where the staff to patient ratio was too low. She worried that he might remove his peg tube again. And she didn't want him to be discharged to a distant facility, as this would be really expensive and it would incur real hardship for her and for her pets. She had 2 dogs that she really loved. And lastly, she didn't want him to be discharged home with in-home services because she didn't feel she could physically or emotionally manage him at home. So given these considerations, her argument was that the best thing for him was to stay in the hospital. And it was in this context in which talk about miracles arose. She said that a little later in the conversations, she said that she believed that a miracle will occur, therefore he should stay in the hospital until it does. So focusing as we're going to on miracle arguments, we do risk giving them too much importance in this case. Just because it's really intellectually interesting or exotic, we shouldn't assume that it was the most important argument that the wife made. However, we don't want to disrespect it if it was made honestly, especially, or not least because of the weight that our culture gives to religion-based arguments. It's also a good opportunity to rehearse an approach to miracles for other cases where the claim is more convincingly made. So we have a number of questions about how the wife used miracle talk in the situation. Does she really believe in miracles? It shouldn't surprise us that she might. Empirically, most people believe in God or some other supernatural entities that they believe do intercede to change states of affairs. If she does believe in miracles, how did she come to it? How did she come to her belief? Was it through her religion? Was it through personal experience? And how strongly did she believe in miracles? Was she an average believer or an extreme believer? And how integral are miracles to her long-held beliefs about the world? Does she pray for a miracle, expecting that her prayers will influence God? Or is it a move? Is she drawing on miracles as a rhetorical move to persuade the medical team? Of course, she can do both. She can both believe and use it as a rhetorical device in a sense. Does she believe that if she pulls the religion card, for example, that she and her claim will be taken more seriously? And how convincing does she think her claim will be? Now, there are a lot of methodological problems or difficulties in trying to answer these questions. I do regret not sort of asking her more questions about her statements. But as clinical ethicists know, it's not always easy to know how far you can go in interrogating these beliefs. We're not the Spanish Inquisition, after all. That's where Monty Python fans will have that sound effect. It's also true that even under interrogation, some patients won't tell you the real reasons for their decisions. The best you'll get will be good reasons. So how do you know when she's telling the truth, when she's telling you what she really believes, and conversely, when she's trying to influence you? All right, so we've put miracles on the table, but we should probably be a little more clear about what either we mean by miracles or what participants in any clinical situation mean when they use the word miracle. So what is a miracle? There's the trivial sense where we might use miracle to refer to something surprising or wondrous. It's something that wasn't really expected, but maybe in retrospect it can be explained. Like we might talk about the miracles of modern science. A second non-trivial but weak sense is when we use the word to describe or refer to an extraordinary occurrence that was unpredictable, was unexpected. It's brute in the sense that it can't be explained, at least for now. And according to this sense, a miracle is an event. It happens. It's an event that happens contrary to expectations. It's presumed that it had a cause, but we don't really know what the cause was. Like a good example, or a simple example might be an apparition, something that appears. It doesn't change anything, but it happens. Miracles in this sense are different to the lottery. Somebody might say, oh, you know, in a lottery, somebody's going to have an event, somebody's going to win. But in miracles, nobody is guaranteed to win. It's not numerically probable. In some senses, this way of talking about miracles is closer to, or has some sort of resemblance to notions of accident or spontaneous mutation, that sort of thing. The third sense is the strong sense of the word. And in this sense, a miracle is not just an event that happens, it's the outcome of an action that an entity makes or takes. That entity has to be, by definition, more powerful than nature. It has to be supernatural. And in this sense of miracle, this entity, like God, suspends ordinary laws and would make an exception for somebody. Obviously, there are doctrinal differences about why God would do this or when God would do this. There are differences of opinion as to whether only God can perform miracles, or can other supernatural entities also perform them independently? Can a saint, for example, do it by themselves, or are they limited to sort of only bending God's ear and getting God to do it, sort of thing? Another doctrinal difference refers to whether God can be persuaded by prayers or rituals or pilgrimages or that sort of thing, or whether he's only going to do it for his own reasons. I think it's fascinating. In our state, the chapel at Chimayo is a site where God is appealed to for divine intercession. So individuals will vary in which sense they use when they talk about miracles, and part of our job is to sort of draw it out. Some people disbelieve in miracles because they don't believe in a God. Some people believe that there is a God, but don't believe that he does miracles. That's a deist kind of God. Some believe that he does do miracles, but only infrequently and only for his own reasons. And some believe that he does miracles fairly frequently, and he can be persuaded to do a miracle by humans. So I think that references to miracles are accepted by some discourses and not accepted by other discourses. So, for example, religious discourses accept and encourage talk about miracles, whereas scientific discourse doesn't. So I think we have two worldviews. One we could call a miracle possible worldview or discourse. And according to this view, we do have to have sort of background expectations to function. We expect things to go fairly predictably, but every once in a while, we allow for the possibility that our expectations might not be met. So there are rules for why things happen, but they can be broken. They can be broken by powerful agencies or entities. Some worldviews or miracle possible worldviews allow for these ordinary rules to be broken by humans, not necessarily by gods or angels, but humans through magic. So anthropology has no end of stories about efforts to control nature or other people through magic. So this worldview, it's hopeful. It encourages a hope that a person may experience mercy, or that God will make an exception for him. It's hopeful to believe that we have some influence over nature and our destiny. If this is possible, then it could be rational to try to induce a miracle, or at least hope for one. The other worldview denies all this. It denies the possibility, certainly, of God-derived intercessions or magic. It presumes that nature is independent, runs by its own rules, and these rules can't be altered. And in this view, nature doesn't care about us. It doesn't care about humans, doesn't care about our suffering. So in this view, it's irrational to either try to induce a miracle or to wait for one. I think we probably should pause here for a second and make sure that we don't wrongly assume that all physicians adhere to a miracle impossible worldview. Certainly there are physicians that allow for the possibility of miracles, but that worldview is far less represented amongst physicians than amongst patients. So these worldviews can be irreconcilable, but even if they are irreconcilable, they can continue to exist separately, held by some people, not held by others, and each letting the other believe what they want to, so long as it doesn't really affect them, sort of a live and let live attitude. But in some situations, they come into contact with each other. And when this happens, there can be conflict. Sometimes the conflict can be reduced by agreeing to disagree when we can, but sometimes conflict is unavoidable, and these are the kinds of situations where we get involved in as ethics consultants. And this type of moral conflict is not uncommon in institutions that are open to all members of the wider society. So we've talked about miracles as beliefs, things that we believe, but they're not just things that we believe in or don't. They can also be used to advance an argument or an interest. So our patient wouldn't be alone in making rhetorical use of miracles. The early Christian church made full use of miracles for rhetorical reasons. Christ's miracles were openly discussed as reasons to accept him as the Messiah. And the early church, the early church's claim to legitimacy was strengthened by its recognition and presumably by its practice of miracles, and the holiness of saints is vouched for by the miracles that they must have practiced. So miracles are also a sign. They are a sign of legitimacy. Now, our patient's wife didn't use miracles in this way. Whether or not she actually believes that her husband will be revived by a miracle, she can't have had any doubt that miracle talk is related to religious beliefs. And because religious beliefs are so strongly protected in the US in the form of legal rights, it is imaginable that belief in a miracle could be protected. She could believe that. And not just as an expression of her religious belief, but possibly also as the basis of a claim on the doctors and the medical team to not discharge her husband. So we're going to talk a little bit more about that. But so the question is, how should miracle denying or miracle agnostic practitioners respond to a miracle affirming patient or surrogate? In our case, how should we interpret the wife's statements about miracles? Were they an expression of her deep and genuine belief, or were they a rhetorical move? We can't know for sure, for reasons that we've talked about. Methodologically, it's really difficult or impossible, but we can try to understand where she's coming from. And we can take two sort of different attitudes. One attitude is generous. A generous attitude assumes that a person's miracle talk is a genuine expression of a miracle possible worldview. And if we start with this default setting, it can help us to keep an open mind and to practice epistemological humility. We can also be aware that people who do believe that miracles are possible may or may not believe that they're likely, and they may make their treatment decisions based on their assessments, not on the reality of miracles, but on the probability of one happening. So an ethics consultant or a spiritual advisor who is respectful of a patient's beliefs can be helpful to the person in sort of helping them to choose amongst options based on probability or other values. Another attitude that is arguably less generous considers the appeal for a miracle less as an expression of a really deep belief or deeply held morality, and more as a rhetorical strategy. And I'm using this word rhetoric a lot, so I should probably define it. Rhetoric is an attempt to persuade another person of something or to do something. It doesn't necessarily require that the first person actually believe what they're trying to persuade the second person of. But in some situations, the politics are such that one person needs another person, but the other person has more power, and the first person needs that person to do something. So they might try to persuade them because they can't actually force them to do so. So Trevor Bibler is a bioethicist at Baylor, and he has developed a typology of beliefs in miracles. And we're not going to go through the whole typology, but he describes some patients who have what he calls an integrated belief. In other words, miracles are part of their deep beliefs. They're congruent with their other values, and they're congruent with their community. Other patients are intrigued by the idea of miracles. So they're not fully convinced. It's not something that they've necessarily grown up to fundamentally believe, but they're open to the idea and they seek them out. And then another group of patients make strategic use of miracles in their interactions with medical providers to reach a desired end. In other words, they use miracles as a rhetorical resource or they use it rhetorically. So Bibler describes a number of hallmarks of the strategic use of miracle talk, including the fact that they are more likely to emerge in a crisis. The person seems to be attempting to gain control over others. He gives an interesting case that he was part of where two sisters were talking about what to do now that their parent was at the end of their life, the patient's life, parent's life. And one sister said, I think that we probably should put, I think his mother, whoever, on comfort measures. And the other sister said, nope, I think we need to wait for a miracle. And the first sister was astonished. She'd never heard her sister talk about miracles, never heard her sister even talk about religion or God. And so it came out of the blue for her. And the interpretation that the first sister made was that it was a strategic use of miracles. Sometimes strategic uses emerge when the decision maker feels powerless or doesn't trust the medical team. And it's often can be identified by rights language. The individual will refer to certain rights to expect a miracle. So in our case, the wife's statements match many of these characteristics, suggesting that she had a strategic attitude to miracles. So what are the, when we think about the strategic use of miracles, what are the strengths, what are the limitations of miracle talk in that way? As we've noticed, or as we've already said, miracles can be seen as the expression of a religious belief, and because religious beliefs, especially in the US, are protected, at least as a negative right, and possibly as a positive right, they have a lot of power in rhetorical power. Arguments based in miracles are not easily ignored. And in some cases, treatment teams have decided not to fight it, just to go with it, or they might allow for a moratorium to allow time for a miracle to occur. The wife's argument was that she has a right to believe in miracles, and therefore she is entitled to make a claim that they not discharge her husband based on that right. So in making a claim, people can be strengthened, their rhetorical argument can be strengthened by powers like that. Powers like, in our case, the fact that miracle talk comes close to religion talk, which is protected in many situations. However, doctors, as recipients of claims like the one that the wife made, can have some sort of immunity to the claim. They might argue that a professional privilege to act that they have a professional privilege to act according to science, in other words, a miracle denying worldview. They might argue that they can't be required to act irrationally. So, for example, if a patient asks the doctor to pray with her for a miracle, the doctor might have grounds to refuse this. So strategic uses of miracles can be effective sometimes, but they're not consistently compelling. I think it's an interesting empirical question as to whether the claims made on miracles are more effective in Roman Catholic hospitals or other religious medical centers than they are in secular hospitals. Would the argument made by our surrogate have more traction in a Roman Catholic hospital? Would she make it, if she was using it strategically, would she make it more vigorously? So what happened in this case? Sadly, well, I don't know, sadly, in the end, the patient died in hospital. So no argument could be said to have won. The medical team didn't keep him in the hospital because it was convinced by her appeal to a miracle or by other arguments. It simply couldn't find a facility that would accept him. So in this sense, the interests of the wife won out. He wasn't moved to a distant facility or back to her home. So in summary, this case was difficult. It was difficult for many reasons. One reason it was difficult was because miracles were invoked in a petition to do more than the team felt was warranted. In other cases, miracles can be invoked to do the opposite, to do less than is warranted. So, for example, a patient or a surrogate might say, I don't want to have surgery. I don't want him to have surgery. I want to pray for this. So these two types of situations can feel morally different. In the one, the claim is to act against one's position, like in our case. But in the other case, it might be that the person is not able to act for one's position. So other cases are difficult because the patient or the surrogate seems to hold deeply held beliefs about miracles. They're integrated into their worldview, into their practices. So it's not just a matter of interests, it's a matter of fundamental beliefs. So how much rhetorical or juridical power does a surrogate or a patient have in those cases? And in those cases, how much immunity does the physician have against them? That wasn't our case, but hopefully in the future we'll have the opportunity to examine these issues in a future case. So wrapping up, what have we accomplished today? Where have we got to? We started off with a case in which the wife of an incapacitated patient made decisions, made claims on a medical team, namely that they shouldn't discharge him. She had some practical arguments to support this claim: convenience, quality of care, cost, and so on. But she also made an argument that her husband should remain in the hospital in anticipation of a miracle. Because claims based in miracles can be made on the basis of deep beliefs, and also because they can be made strategically, we have to come up with methods or ways to try to distinguish the two. In this case, the appeal based on a miracle was interpreted as strategic and almost half-hearted. It might have been a good reason, but it wasn't the real reason. So this relatively easy case that we've presented, we can talk more about, reveals that a religion referencing argument is not inevitably compelling, but we have to be open to situations where they can be. So I'm going to stop talking now. We have 10 minutes to talk. And I'm sorry, I wasn't able to focus on the chat room. I'll open it up now. In case I forget, we are also going to send, Ramona's going to put up the HSC ethics email address, and we can have a conversation through that venue. So any thoughts, any reactions? How do you handle miracle talk?
Jonathan,
Yes,
Arup, do you think that the patient's wife had the idea of keeping her main goal was to keep him in the hospital, and not really believe that he would recover. You think that could have been the case?
I think it's possible. I think her first objective was to keep him in the hospital. How strongly she believed that he will or won't recover, I don't know. But clearly her primary objective was to keep him in the hospital. I think if I had to guess, I would assume that she didn't really believe he was going to recover. Why do you ask, Guru?
I feel that many patients use that tactic of miracle will happen and save my whoever the patient is, and they just use that as a method to keep the patient in the hospital or to get their own values fulfilled by using the word miracle.
Yeah, I think that we do, and that's the strategic use of miracle. And I think we do have to be alert to that. I think we can't assume that every reference to miracle is strategic. And that becomes the problem. How do we tell the difference? Has anybody encountered miracles in their practice?
Can I say something?
Yeah, hi, Pankaj.
So many years ago, not in this country, in my own country, we had an 11-year-old boy who came with acute hepatic failure, and he was really sick. He, without a liver transplant, would have died. For one reason or the other, he could not get a liver transplant. We just could not find a donor for him. The family said, we'd rather take the child home alive rather than take him dead, because we are going to be stopped on the way if we're carrying a dead body, even though we have a certificate from you. We want to take a child back home alive. They took the child back home alive, though he was barely alive. And I was convinced in my head, and so were 4 other physicians who were well experienced in this situation, that this child would die. 2 years later, he went to another state about 1,000 miles away. 2 years later, he came back and met me, and he said, hey, look at this 11-year-old. He's now a 13-year-old boy. He's totally normal. You said he's going to die. But you know what? We took him to our temple, and we kept him there, and we prayed, and this is the result. I think he would have died if he stayed in your hospital, because you were not transplanting him, and we would not have taken him we could not have physically taken him to that temple. And he said, that was a miracle. Now, if you look at acute liver failure, when you have stage 4 acute liver failure, the likelihood of survival without a transplant is roughly 10%. Really hard. And this guy fell into that 10%. They had faith, they had belief, and they thought that a miracle saved this kid. It was a great outcome. It was a learning exercise for me.
What did you learn? What changed for you, Dr. Vora, as a result of this?
That listen to the parents. If you're not going to get into trouble legally at some point in time, or from your hospital for releasing the kid who was about to die, but was not dead yet, because of the conviction of the family and the trouble they would have had if the child had died and they wanted to take the child back to their village 1,000 miles away to cremate him. And I agreed. And I let go. I was against the other physician. I said, no, let him go. We're not doing anything for him. We've tried for the last 2 weeks. The guy gets worse every day. Let him go. And so I think you have to be a doctor, but you also have to be a human being.
Copy. Yeah. Thanks, Dr.
We conflated a couple of things that I think might be worth separating. We talked about using a miracle claim to demand care that the team might think was inappropriate, or to refuse care that the team might think was appropriate. But as I understand it, the right to refuse care for a competent adult is nearly absolute, whereas the right to demand care is much more conditional. For example, I remember a guy who overheard that the CT his daughter was getting wasn't as expensive as the MRI someone else was getting, so he was demanding the MRI. Well, that's the wrong test for blood in the head. It just isn't even the better test. It was simply more expensive. He doesn't have a right to demand that, but he would have had a right to refuse the CT in himself. It was a minor, so we wouldn't have let him refuse the CT, but for himself he could have. But he couldn't have demanded the MRI. So I'd separate those.
No, I take your point, and they are asymmetric. I think that the moral distress that clinicians would feel is different because of that asymmetry, and I'm glad you pointed that out. Yeah. Any other thoughts about? I'm curious. How many of us believe in miracles? That, in that strong sense, I think Dr. Vora probably referred to miracles in the second sense. But I wonder, maybe it's not polite to ask, but for our population today here on this meeting, I wonder who has strong beliefs that miracles in the sense of God created actions. Yeah.
I have a sincere question about this. I've thought about it for a long time. If people believe a divine power can grant miracles, and this divine power is either absolutely perfect in their judgment or way better than we are, how does it even make sense to ask that divine power to change its mind? I'm not joking. I'm serious.
Oh, I know. It's and I think that's where this doctrinal difference as to whether God is listening to us, whether we have a right to claim God's ear, can emerge.
I think differences in families and physicians' perception on kind of, say, intervention puts the clinician to the ultimate challenge in terms of trying to respect beliefs, but at the same time try to work towards a mutually agreeable outcome. And oftentimes when the disagreements are very severe, somehow there's been a fractured relationship, in my experience, when there's a difference between what the family wants and what the recommendations are from the team.
Definitely, and that's the conflict situation. That's when ethics consultants can be brought in. And there are two types of situation where we seem to have most relevance. The first is where there's an uncertainty about what the right thing to do is, and that one or more parties to the situation can talk about their uncertainty with an interest in trying to come to a stronger belief or conviction. But the other type of situation, it's already a conflict. And the type that you described is the conflictual situation. That's what we had here. And that's where it gets much more difficult. Oh, Brett, could you say more about the placebo issue? Brett Mabry is there. So you can see in the chat, Brett said, we may have misrepresented medical science as accounting only for interventions with surgical or chemical administration points, but there's a long history of placebo effects and other variables in that vein of belief operating in the mechanism of recovery. I wonder if that would endorse a use of placebos. Is that something we should go along with because we know it is concurrent with a person's belief? That might be topic for another talk. So we're now at the 1 o'clock time, and please come back next month, second Tuesday of the month. Dr. Paul Roth is going to talk about his experiences as our paramount leader for so many years, and things that he has learned from other leaders and things he would like to pass along to us under the banner of organizational ethics. So thank you all for coming, and hope to see you next month. Bye-bye.